already, most people will survive prostate cancer. And so, just a little background about myself. From the Chicagoland area, did a lot of my training here locally. Then went out to Nebraska for residency, and then been back here in practice now about 11 years, and with Northwestern Medicine's regional medical group, with offices in Geneva and soon to have offices over in Winfield as well by Central DuPage Hospital. So just a little background, just so we're all on the same page and a foundation of understanding. The prostate is an organ that sits right between, so let me get my cursor here. So it's an organ that sits right between the urethra and the bladder, right? And so it has a lot of key functions in urinary control and also sexual function. And so I think some of that understanding can be critical as we kind of go through some of the outcomes of what prostate cancer treatment can lead to. With prostate cancer, I want to really focus on treatment and survivorship. Obviously, as Ashley said, one of the main focus of this talk is overcoming prostate cancer and living with prostate cancer. But before we get to that, I think it's important to understand why we screen and how we detect prostate cancer. And so I will talk a little bit about those. And the way I broke this presentation up is kind of just dispelling some common myths. I targeted 7 myths out there, and with that, I think it'll help kind of better kind of hit home, I think. So number one, prostate cancer always has symptoms. Typically it doesn't. Most men are usually asymptomatic. They usually don't have any symptoms whatsoever. And typically symptoms are usually a sign of later stage disease and more aggressive disease. And so some of those symptoms can include blood in the urine, back pain, frequency and urgency of urination. But again, most men do not have symptoms. Secondary, an enlarged prostate does not necessarily mean cancer. So I commonly will hear, I have enlarged prostate. And so that doesn't necessarily mean you have an increased risk of cancer or prostate cancer whatsoever. Really what that means is that's something that's very common as you get older. And additionally, it can just happen simply with aging. And so those terms are not synonymous. It only develops in the elderly. Now, prostate cancer is a disease of aging, right? The mean age of diagnosis is nearly 70 years of age. However, there are patients who get prostate cancer at a much younger age. And there are risk factors for that. Obviously, if you have a family history of prostate cancer, if you have a family history of breast cancer, ovarian cancer, that also can lead to some increased risk of prostate cancer. And so for that purpose, I do want to kind of hone in on some of what is meant by family history. And so, as I said, prostate cancer is not necessarily something that happens only as you get older. It can happen at a younger age. Nearly 250,000 men are diagnosed with prostate cancer annually, which pretty much equates to about 1 in 7 men in their lifetime getting prostate cancer. However, that being said, basically what I'm saying is that with that being said, vast majority of men do not have a family history, right? So the number of people who are getting diagnosed outweighs the people who have any family history. And so that's why it's important to be something to consider or get screened for despite or in spite of you not having a family history. And so as we're kind of talking with screening, and this is directly out of the National Comprehensive Cancer Network, or the NCCN. It's a great guideline and resource. It's great for clinicians. We use it all the time. Additionally, I think it's great for patients. They have a lot of good patient education materials for prostate cancer, among other cancers. So I do recommend you seek it out, whether you're personally going through a cancer journey or if you have family members or loved ones. I think it's a great resource. But I put this slide here because I think it's very critical to understand kind of why we screen. And I'm going to kind of break this up in the next few slides. And so I think one of the most important things for prostate cancer in regards to screening is getting a baseline PSA. I think I can't say that enough. And so typically, I would say maybe 10, 15 years ago, we would say, hey, we're just going to get a PSA after the age of 50, almost similar to like a colonoscopy where you got that at the age of 50. It was kind of a set it and forget it mentality. But I think the importance is that because there is a risk for patients getting prostate cancer at a younger age, especially if they're African American, especially if there's a family history or if you've had genetic testing done for some other reasons and you have a BRCA mutation. I think it's important to get a PSA at the age of 40 at a baseline. Now, that doesn't mean you get a PSA every year afterwards, but it just kind of helps understand where you sit. Again, if you don't fall into these criteria, I think a PSA at the age of 45 is fine. And I think a baseline rectal exam is still important because while it's not going to detect or help detect a majority of cancers, it still can pick up to 15% of cancers. And so because of that, I think it is important to kind of get a full workup early on. Now, as I was saying, if you had a PSA done and it's less than one, you don't necessarily need to get one every year. There's plenty of studies, plenty of research that's been done on PSA values showing that the lower the value is, and especially if it's less than one, the chance of you having prostate cancer or even developing clinically significant prostate cancer is extremely minimal. And so in those patients, we can spread out screening. And screening of a PSA, or which is the prostate-specific antigen, is a simple blood test. So it doesn't seem like it's too much. But again, if we can eliminate unnecessary tests, I think you're at benefit because there's one less thing you have to remember to do as a patient. And then two, I think the overall healthcare system benefits as well. Again, and then obviously if your PSA is greater than one, we will screen you a little bit more often from every 1 to 2 years. Now, it's not something that goes on infinitely. At some point, we do stop screening. And that's basically for a variety of reasons. One is the benefits of actual continual prostate cancer screening after the age of 75, or if you have a lot of other medical problems, doesn't have much benefit. They find that the risk actually, whether it's the actual biopsy or potentially the risk of treatment, far outweigh the actual benefit. And so again, these are some decisions that you'd sit down with your urologist and we would decide together to see what the best option would be. Now, one of the other big myths is that a PSA is used to diagnose prostate cancer. It's a screening tool that leads us to kind of consider when we should do the next steps, but it doesn't diagnose cancer. So I've had plenty of patients who've undergone a full workup who have PSAs in their 20s or 30s or even in 15 or 16 and they don't have prostate cancer. I also have patients who have PSAs that are 2 or 3 and have prostate cancer. And so the PSA is not a perfect test, but it's a great test to kind of help guide what other things we should do and maybe do a biopsy. And so anytime the PSA is above 3, or if you have an abnormal rectal examination, I think that's something that's going to lead us to a next test, which is a prostate MRI. And then if you're older than 75, typically we'll look at a PSA above 4, or an abnormal prostate MRI in those cases. And again, there's patients who are older than 75 who are extremely healthy. And so those patients still might get screened. And that's kind of how those still kind of come into the picture of detection for us. Now, the reason I mentioned the prostate MRI, I think what's conventionally changed, and I remember this about 9 or so years ago when a prostate MRI was coming into the marketplace. There was a lot of skepticism at that point of saying, how is this going to really help change our clinical practice? And I think it's one of the biggest pieces of radiological imaging that's come in, and it's kind of changed the pathway of how anyone practices urological medicine and picking up and detecting prostate cancer. I think a vast majority of our patients in this day and age do get an MRI before a biopsy. And I think that's almost critical because one, it can eliminate a lot of unnecessary prostate biopsies and help us kind of hone in on prostate cancers that are clinically significant. Additionally, there's additional tests that we can do. There's biomarkers. One of the most commonly used ones that we do at Northwestern Medicine is the Prostate Health Index. The Prostate Health Index is, again, just a blood test, but it kind of takes into account a couple different forms of PSA and comes up with a risk calculator to say what's your what probability of having prostate cancer, and that risk can definitely help uh, hone us in on potentially doing a biopsy. So I've had patients who've had a negative MRI, but at that point we're like, hey, could we get some more information to see if this patient need a biopsy or not? And the PHI has been a useful test. Additionally, something that's simple that we'll do is, let's say you had a PSA that was out of the norm from all the other PSAs you've had in your life. Sometimes we'll just repeat the PSA. 25% of the time, that repeat PSA, if it was between 4 and 10, will come back normal. And there's a lot of different reasons for that. One, it could have been you might have had a little bit of a urine infection. You might have been doing some type of strenuous activity. Again, it's something to keep in mind where we want to try to avoid unnecessary workups. And I would say a prostate biopsy, again, lots of advances have come even in that arena. But again, if we can avoid the risk of that safely, that's something we would strive to do as a urologist, and something I strive to do in my practice. So some of the stuff that I've already kind of hinted on our last slide, again, a normal prostate MRI can avoid up to about 30% of biopsies. Some other type of PSA, which is a percent free PSA, which means the PSA that's not bound to protein. So basically the floating PSA, the higher that is, the less likelihood you have prostate cancer. And that being above 25% can avoid up to 20% of biopsies. And so I think these are tests that we can use to make safe and smart clinical decisions to, again, minimize unnecessary risks. But again, they're not perfect measures. And so again, it's a discussion that you would have with your urologist and looking at the pattern of the PSAs before you just maybe had a one-size-fits-all mentality. Prostate cancer requires immediate treatment. I think one thing with this is that, again, another big change that's happened in practice. It's happened a lot in urology, and I'm sure in other fields as well, where certain diagnoses don't necessarily mean treatment right away. And prostate cancer, about 50% of low-risk prostate cancers are managed with active surveillance, which means periodic PSAs and periodic prostate MRIs with surveillance biopsies every 12 to 18 months, and then often spaced out even further. And again, the importance that I want to make with this is that just because you have a diagnosis of prostate cancer does not mean you have to have treatment. And the reason we would defer treatment is, one, we can minimize any risks that are associated with treatment, and two, we can prevent any detrimental impact to your quality of life, which I'll touch on here towards the latter half of this presentation. And so again, if we can safely do things with deferring treatment, that is the new push for prostate cancer management. Now, not all prostate cancer is low risk, as I was talking about previously. This is just for historical purposes. We've kind of moved away from the Gleason score, which was where the pathologist looked at the cells under a microscope and came up with a score, with 3, 4, and 5 being the more aggressive patterns and 5 being the most aggressive. And we've kind of gone to something called a grade group. And so usually, as I said, the pathologist looked at this Gleason score, looked at the 2 most common patterns that it's under the microscope, and came up with this Gleason score, which sometimes got a little confusing and muddled. And so we basically break it down now from group 1 to 5. And so if you have a group 1 or 2 prostate cancer, a lot of times this can safely be watched for sometimes many, many years and maybe a lifetime. Again, there are other cancers that are more aggressive from groups 3 to 5, and those are the ones that treatment definitely comes into play. And so for the remainder of this talk, I'm going to really focus on treatment and really more so on the impacts that treatment have. And so there's a multitude of treatments. Some of you may be already familiar with this if you've gone through a journey with prostate cancer. But just for completeness sake, and so we're all on the same page, you know, there's surgery, there's radiation, and then there's other options as well, such as nanoknife, which is delivering electrical pulses to cause targeted cell death, cryoablation, which is again freezing the prostate, and then something known as high intensity frequency ultrasound. And so Um, Surgery is typically done in the hospital. It's usually a overnight hospital stay. You usually have a catheter for about a week. There's about a 4 to 6 week recovery period, sometimes longer, but 4 to 6 weeks we can't do any heavy lifting. And some of the main side effects of surgery are erectile dysfunction, incontinence, and infertility. Now, many men will regain uh, their issues with erections and incontinence, but there is a lasting impact on this, anywhere from 5% for erectile dysfunction to sometimes a little higher for incontinence. And I do want to stress that erectile dysfunction is not a result of prostate cancer. It's really a result of the treatment. And with that, I want to talk about the last myth for prostate cancer is that erectile dysfunction is caused by treatment, right? So surgery can cause it, radiation can cause it. Really, any type of treatment for prostate cancer can cause it. It's highest with cryoablation, where it's on the order of 90% or higher. But again, the likelihood of having issues with erections after treatment is pretty high. I saw a patient earlier today in clinic who, I was counseling, who had a grade group 2 prostate cancer at diagnosis, and I was counseling on different treatment options. And I did mention to him about this erectile dysfunction, and he kind of leaned in and then told me that, yes, he had some baseline issues. So a lot of men coming in, unfortunately, as they get older, will have issues with erections, whether it's due to high cholesterol, diabetes, prior smoking history, so on and so forth. And so all those things kind of have some baseline foundation in some of the future impact. And so these treatments are only going to further aggravate it. And so that's something that I do want to stress, that erectile dysfunction is a very common side effect of prostate cancer treatment, regardless of what you undergo in terms of treatment. Radiation, its side effects are cumulative. So while radiation might necessarily have side effects right off the bat, if you live long enough, radiation unfortunately will likely lead to some type of side effect, whether it's issues with erection, leakage of urine, blood in the urine, having sometimes issues with the intestines like diarrhea. And again, radiation has come a long way as well. I think we have more targeted radiation. As I talked about, something called cyberknife or stereotactic radiation, where it can really target in and kind of provide any high intensity radiation for a few sessions, to very much proton beam radiation, which is also very focused radiation. But that being said, they'll still have very similar side effect profiles. Other therapies that are out there, I think these are pretty new in the sense of treating prostate cancer. The data is still limited. A lot of these are done right now in clinical trials or at a smaller center or a smaller patient population at this point. And really, the patients they're really considering for these targeted therapies, where maybe you're not treating the whole prostate, they're really treating the area of the prostate that was abnormal or had cancer, are patients who had low risk prostate cancer. So they either had grade group 1 or grade group 2. And so these patients could have probably just been watched. And so the benefit in these patients of getting these types of treatments versus simply watching is it's still yet to be spelled out. And these treatments, unfortunately, still have issues with erection and other issues. And so you're really not maybe necessarily getting much benefit in the primary treatment space with these modalities outside of a clinical trial at this time. Now, with metastatic prostate cancer, unfortunately, we do diagnose those cases, sometimes at presentation or sometimes with recurrence. Treatment really isn't really definitive in terms of surgical removal. Some other disease processes, in urology, like let's say kidney cancer, even if you have metastatic cancer, we can remove the kidney to provide a better overall outcome. For prostate cancer, that doesn't really exist. Now, there is a role of radiation for pain you might have with the disease burden. There's also a role of chemotherapy and hormone therapy. And hormone therapy is the simplest way of putting it. It's kind of putting you through male menopause, right? So it can basically cause issues with hot flashes, weight gain, fatigue, sometimes impact on the bone health. So increased risk for osteoporosis or even osteopenia, which is weakened bones. And what they've basically shown is also patients who have maybe baseline underlying heart disease might have a higher risk for it. But physical activity can sometimes curtail that risk. So it's kind of a way to curtail some of this. But again, there are treatment options for people with metastatic disease. Again, it's come a long way in the last, I would say, last 3 to 5 years, where it used to just be hormone therapy, right? All you was like an injection that you'd get in the office or pills. But now there's many other oral medications. There's immune modulator medications. And so again, the research continues to evolve in prostate cancer. So even if you had a more aggressive form, there is options for prolonging your overall survival and decreasing the chance of this cancer getting worse. So with that, I kind of want to focus in on the remainder of this talk. And I don't know if there's any questions at this point where I shift kind of gear. So, and if there's not, then I'll kind of move on. Okay, hearing silence here. I imagine we can continue going here.
A reminder to everyone too, you can put questions in the chat if you want, or you're welcome to unmute. So if you have a question that pops up as he's going forward, just let us know.
All right.
There's one, Dr. Desai. Do you see that in the chat?
I'm trying to scroll over there. Yes, let me see here. Yes, let's see here. So, yeah, so there's a question, I think it's really timely since I just talked about fatigue. And so basically, there's a lot of different ways to combat fatigue. I think one of the things is physical activity, right? So I think exercising, and what I mean by exercise is about 4 hours of cardiovascular activity a week. I think that definitely is beneficial. I think that's one way. I think nutritional, or I think optimizing nutrition, and so in terms of healthy eating. And so again, many times, and I don't know about you, for our participant who did send in the question, if you have any underlying medical conditions or not, but if you have high blood pressure, minimizing salt in your diet and so forth. I know some of the programs they do at Living Well do talk about healthy cooking and different diet things, and there's definitely programs that I'm sure Ashley can kind of send information your way on that. And so I think those are some things that would definitely be considerations. Alrighty. All right. All right, I'm just trying to click back to the screen here.
Can I ask a question while you're doing that?
Yeah, of course.
Thank you. Yeah, I had surgery, removal of prostate in April, and then found that the cancer had metastasized. So I've gone through 36 treatments of radiation, and now I'm also on the hormone suppressant drug injections and pills, and I have experienced fatigue. My medical oncologist has kind of reminded me that the drug itself does a little bit of masking on subsequent PSA tests, and that until really I'm off of that drug, maybe in 2 years or even longer, a little bit, the PSA, unless it spikes in the interim, it really is going to be somewhat masked by the drug. So it's really after about 2.5 years that PSA would actually show if something has occurred, that was perhaps not totally destroyed through radiation. I also know that in general, I'm kind of living with this because it's in the bloodstream and there's, cells, but, they can't kill all the cells. The likelihood of it landing somewhere and growing is probably less. But I would ask that question about the masking of the in the PSA test, and how common is that? How concerning is that to you?
So yeah, so I mean, there's something called a PSA bounce phenomenon, and I don't know if you're a radiation oncologist or your urologist had mentioned that to you, uh, Steve. But basically, what the bounce phenomenon is sometimes the PSA can sometimes go up, right, while you're on some of these medications right after you've completed radiation. But the true recurrence would not necessarily be that wouldn't be considered a true recurrence, because the PSA then can kind of, what I would say, stabilize, right? And so the PSA sometimes takes some time to stabilize and kind of get to what we like to call the nadir level, and that's going to be your steady state PSA. And so fluctuations from that are what we really concern ourselves. And so, after you've had, let's say, removal and then radiation, your PSA is never going to, and it might on some occasions, but for most majority of men, it's never going to be undetectable. And what we're really looking at is a deviation of the PSA going typically 2 points above that nadir level. And so I think it's not overly concerning unless that number just keeps rising, right? So if you get your first PSA, it's 0.5, and then it goes to 1.0 or 1.5, and it keeps going up, then that's concern. That's concern that maybe, we'd involve our oncology colleagues, or maybe the urologist would consider adding additional therapy for you.
Thank you.
Okay. No, you're welcome. So with that, again, it seems like there's some people obviously living with prostate cancer. Obviously, as I kind of started off with talking about, and I'm sure you guys, if you're going through a journey already, know that you're going to survive prostate cancer. Vast majority of men who are diagnosed with prostate cancer survive it. Only 3% actually have mortality from it, whereas about 14 or 15% annually are diagnosed with it. And so some of the main issues of survivorship that really impact men are erectile dysfunction and urinary incontinence. And I'm going to focus on these two topics in some depth here. Now, as I kind of already talked about erectile dysfunction, there is some baseline issues. 1 in 2 men after the age of 40 will have baseline issues. 1 in 5 after the age of 20 years old experience some type of erectile dysfunction, and it impacts almost 40 million men. And it varies in percentages. As I said, maybe about a 5% residual after prostate cancer removal, about 2 years, but it can be a lot higher because of some underlying conditions like high cholesterol, diabetes, or if you have to have radiation on top of your surgery. And so these numbers can creep up to 50 to 75% in patients. And why is this so important is, I think, is we kind of talk about prostate cancer and a journey. And I think in terms of any cancer, I speak of it to a journey almost. It's about quality of life, right? And so when you survive cancer, which many people these days do, which is great due to our new technology and our newer drugs and the research that we have out there that continues to advance the forefront of cancer research and the ability to overcome cancer. But you're unfortunately left with side effects. And these side effects have a strong impact on anyone's quality of life, whether it's impacting their social functioning, whether it's impacting their relationship with their significant others, psychological. And so that's why it's really important to be aware that there are options out there for these. Excuse me. And so there's a lot of different options. Some of these you probably have already heard of, medications, whether it's a Viagra or Cialis. All these medications are generic, and I still find it surprising, probably less now, than maybe 3 or 4 years ago, of men who don't realize these medications are generic. And despite that they're generic, that going to like a GoodRx is a lot cheaper than going to their regular Walgreens or CVS. And so GoodRx is actually a prescription savings card. It's taken anywhere. But ironically, and this is just basically because of the complexities of the medical field, medical insurance industry, and I mean, honestly, the pharmaceutical industry, that like taking this GoodRx card to a Costco or a Walmart or Meijer will get you the same medication with the for like 25% of the cost as if you went to like a Walgreens or CVS. And so some of you might have heard of like Mark Cuban and his pharmacy ideas, or Amazon trying to do, and that's kind of the principle behind it, is that they could get better prescription plans. And so these medications are generic. So it's really not something that is something that's cost prohibitive as it once used to be. However, it doesn't work for many men because of some underlying conditions. Number two, obviously radiation and surgery can make things a lot more challenging. And so with that, there are other options. Now, vacuum erection devices or vacuum pumps, there's a lot available on the internet and so on and so forth. I caution you on this, that for a vast majority of men, these don't work unless the pills have some benefit. Similarly, there's a lot of advertisements on the radio and billboards and stuff about shockwave therapy. And shockwave therapy, unfortunately, doesn't work for most men who've undergone prostate cancer treatment. It's really for men in the short term, for potentially where the medications are helping and maybe helping them kind of get off the medications temporarily. But again, it's a short-lived effect, where studies in those patients who did have any benefit was for about 6 months only. And again, I always caution my patients to kind of do their due diligence, talk to the urologist, because a lot of these therapies, especially the shockwave for the penis, is being done by non-urologists, almost 80%, and it's something that's not covered by insurance. And so there's a reason why that is the case. Injections work, right? Injection therapy is something that works, but it's sometimes cumbersome. You have to keep the medication on ice if you're traveling, or in the fridge. And so one of the things that can almost is more natural and kind of help restore your erectile function and kind of help restore your quality of life is a penile implant. A lot of times men who've never heard of this kind of give me a second take. They're like, what's this? And again, it's a very minimally invasive outpatient procedure, which again, it's not for everyone. But again, I think the reason I bring these things up is that the biggest thing that most men will unfortunately deal with in their lifetime is not dealing with, passing away from prostate cancer. It's the side effects, and there are concrete solutions to help overcome these side effects. And again, patients and partners are very well satisfied. Shifting focus to the second most common complication from prostate cancer treatment is incontinence. Now, people develop issues with urination even if they didn't have prostate cancer or treatment, right? Almost 55 million men worldwide have issues with urinary problems. That equates to about 5 million men just in this country alone. And so again, the one thing I want to basically drive home throughout this talk is that prostate cancer itself does not cause these problems. It's actually more often than not the treatment. And these treatments obviously have impacts, and this incontinence impact, I think, is one of the greater ones that many men don't realize that, hey, there is a very simple solution to this, where you don't have to deal with the negative impacts on your quality of life, whether it's depression, just feeling like you can't go outside, worried about finding a bathroom all the time. And so, excuse me. So you don't have to just live with the pads and diapers. These are costly, typically not covered by insurance. They're cumbersome, right? You have to worry about changing them. You worry about, hey, is there a smell coming? So ways to overcome this are simple as sometimes just a conservative option. A conservative option could be as simple as physical therapy. It's actually been shown that physical therapy, and it's specific to men's health, right? So it's not the physical therapy you get for your bones or other types of physical therapy you might conventionally know, but this actually can help with regaining urinary control. Additionally, it can help regain erectile control, because sometimes the muscles that are responsible for erection can get weakened after prostate cancer surgery. So again, it has a double win standard, and it's something that doesn't require any more effort in terms of surgery or anything of that nature. Additionally, something known as a Cunningham clamp. Now, I am still surprised how many patients I've seen, who've seen other urologists in the past who come to me for second opinions, have never heard about a Cunningham clamp. Now, again, not for everyone. It might be potentially discomforting, or it might seem too barbaric, but really putting a clamp around the shaft of the penis, as kind of demonstrated here, can be quite beneficial in cutting down a lot of pad use for patients who have a lot of incontinence issues. Again, it's pretty inexpensive. It's about $30 on Amazon. And so again, a very simple solution. But again, that being said, people sometimes want a more natural solution in the sense that, hey, I don't want to deal with any external appliance. I don't want to deal with pads or any of that. So what else do we have? And for those patients, there are a couple of surgical options. And these options, again, are really aimed at helping a patient regain their dignity, and a lot of times resuming intimacy and avoiding those costly garments. And so I think as many men kind of go through this journey, I want to, again, stress the importance of being aware that there are ways to overcome some of the issues you're dealing with. And I think simply asking your urologist or asking your healthcare provider to get you the right resources is something that I would recommend. And as I was kind of hinting on, some of the surgical options, again, one is a sling outpatient surgery, very similar to a female sling, because the prostate is very similar to the pelvic floor muscle that for females. So if they have their childbirth, they have weakened pelvic floor muscle. And so similarly put, the male sling can kind of help regain that lost pelvic floor support after a prostate's removed. Now, if you've had radiation and your prostate removed, or if you have a significant amount of leakage, that option that I mentioned before in terms of the sling is not really going to be beneficial. And so almost kind of an implant, which is an artificial urinary sphincter with an overnight hospital stay, could be something that could benefit you. Now, again, these pieces of technology have not undergone many advances in the last 10 to 15 years, but there is a lot more in the pipeline where there's talks of this being automated. And so you don't have to worry about the little pump that's shown here. And so things are continue to evolve. And so I think I preface this with telling people that this might not be for everyone, but there is an option for you if this is bothersome. And I think you don't have to just live with it. And so before I open it up for questions, I do want to point out that prostate cancer is something that we do not want to ignore. Even though I spent a lot of my talk on talking about most men living and overcoming prostate cancer, there are cancers that can be fairly aggressive and cause a lot of issues. I know there's patients who have metastatic prostate cancer. And so again, we want to pick those up because it's a cancer that it's curable, or even more so, it's the cancer that even if it's spread, we can definitely put the disease at bay for many, many years with some of the newer medications and options we have out there. There's no perfect screening test. Obviously, an MRI does help us greatly. It's pretty much standard of care at Northwestern Medicine for all men to undergo a prostate MRI before a biopsy. But it's unless there's some kind of condition that precludes the patient from getting an MRI, like a cardiac pacemaker or so on and so forth. But again, vast majority of men can get this without an issue. Number three, I think it's very important for genetic testing, especially for patients who have a diagnosis at an early age or a strong family history of prostate cancer, breast cancer, ovarian cancer. I think the genetic testing is very important to help identify potential family members or loved ones who might benefit as well from genetic testing or early screening. Prostate cancer itself never really causes any side effects. It's really the treatment or any type of treatment for prostate cancer. And finally, the quality of life, the impact on quality of life that any treatment has, whether it's surgery, radiation, it doesn't have to be permanent. There's definitely many options out there. And I think you just have to ask the right questions. And hopefully this has helped kind of guide that. And hopefully, even before you ask the questions, your urologist is offering this and considering these things, because again, it's all about kind of living and overcoming in a journey as opposed to a single instant in time, in my opinion. And so with that, these are some great resources, and I know this presentation will be on the Living Well YouTube channel, which will be a link at the end. But basically, great websites, I think, for a lot of education, even beyond the National Comprehensive Cancer Network. I think they have great resources for patients. So